Hi, I'm Dr. Raney. I'm from Durango, Colorado. I chair the APA's work group on integrated care. Today we're going to talk about the definitions of collaborative and integrated care. I want to start by saying these terms are used interchangeably, so they basically mean the same thing. The way I think about it is that systems integrate, and that's administratively, and professionals collaborate. Those are the interactions we have on a day-to-day basis on these collaborative care teams. So you'll hear me use that terminology interchangeably as you will other people in the field. Integrated care is a structured approach to healthcare delivery where behavioral health and medical conditions are treated concurrently. The important piece here is the structured approach. Let me define what I mean by structured approach. There are four basic principles that we follow in these collaborative care teams. The first is that it's team-based care. You assemble a team of a primary care provider, a care manager or behavioral health provider, often a social worker or a psychologist, and a consulting psychiatrist. That's your team. The second principle is that we use evidence-based treatment. The collaborative care model itself has an extensive evidence base, but also we use the pharmacology that we use, the brief interventions that the staff use are all evidence-based. The third principle is this is measurement-based care. From initial screening of patients, rating scales are followed throughout their treatment, and we work to treat to defined targets. And then the third principle is we're doing population health. We're taking responsibility for a defined group of patients. This could be all the patients in a primary care clinic, a group of patients with diabetes, pregnant women, or children in a pediatric clinic. But we define the population and everyone receives a set kind of screening and care. Everyone gets screened within those populations with tools that we have defined up front. Working at this population level allows the consultant psychiatrists to extend their expertise across a larger population of patients. The consultant psychiatrist is doing a number of things. They're providing ready access to telephone consultations for both the primary care providers and the behavioral health providers that are on the front lines in the clinic. The behavioral health providers in these clinics are required to track patients in registry. That's part of the population management. On a weekly or monthly basis, the consultant psychiatrist will come into those clinics and review the registry with the behavioral health provider, looking for patients who aren't improving, who may have fallen out of treatment, and making recommendations on additional things that they can do. So in the course of an hour, instead of seeing one or two patients, as the psychiatrist may normally see, they're able to provide consultation on 20 to 25 patients, really extending your expertise again to a larger population of patients. This can help us with the workforce shortage we're currently experiencing in the country because we're able to extend again that expertise to a larger population of patients. If this structured approach is followed, there is a robust evidence base that shows that collaborative care can improve outcomes, it can contain costs, and actually has a return on investment of $6.50 for every $1 spent, and can increase both patient and provider satisfaction. Psychiatrists will need to learn about these models, learn about their role in these models, and how to be leaders in these collaborative care teams. And training for that is currently available and can be found on the APA website. Working on integrated teams is the future for many of us in psychiatry, and I really encourage you to join us.